A very good evening, everyone. Once again, it really gives me great pleasure to welcome all of you this evening to the second in the series of virtual update webinars, now organized by the Neurosurgical Association of Malaysia. This is a collaborative effort between NAM, the Neurosurgical Association, as well as the WFNS, particularly under the aegis of Professor Hari Chandan, the second Vice President of Australasia, and Dato Kanta, the President of the Neurosurgical Association of Malaysia. Now, uh, today we have an interesting topic and many esteemed speakers lined up to be able to share their knowledge and expertise on the topic of the emerging topic, I would say, new and developing change in neurosurgical practice for trauma, cisternostomy. Before I introduce the panel, please allow me to pass the screen to Dr. Kanta Rasadingam, the President of the Neurosurgical Association Malaysia, to just say a few words. Dr. Kanta, over to you.
Hi, good evening, everybody. Thank you, everyone, for joining us. I would like to thank Professor Iype Cherian, Professor Parthiban, and for this topic webinar. I would like to thank all of you, yes, and I get more webinars like this. So, without wasting time, please webinar. Thank you.
Thank you, Dato Kanta. Thank you. Now, dear friends, I mean, trauma is a major public health concern in this part of the world. I think all of us here agree that, it takes, it contributes very significantly to morbidity and mortality, particularly at the young age. And treatment essentially is medical management with your decompressive hemicraniectomy when all else fails. Not much has changed. And I mean, the concept of cisternostomy is not absolutely new. Drainage of fluid out of the cisterns has been utilized in various other neurosurgical conditions. But following the work of Iype and his team over the time, where further establishing the role of gliolymphatics, I believe and I understand that there's a lot more research supporting this treatment modality. And today we have three esteemed speakers with us who will highlight not only the principles behind these techniques, they will go into the nuances of surgical practice, and as well as outcome parameters and where we're heading in our, I would say, in our attempt to bring this treatment to the fore for the future. Now, the first speaker for this evening is my dear friend and mentor, Professor Iype Cherian. Professor Iype Cherian is the professor and head of neurosurgery in Bhartpur, and he has been involved in groundbreaking work in neurosurgery, as I've mentioned, in the field of cisternostomy and skull-base and vascular work. He's the Counselor General for the ACNS and has innovated many educational programs. He's an integral part of Neurosurgical TV. He's come up with the Neurosurgery Coach Program and has recently launched a journal, the Ignite Journal, which I think all of you would have been exposed to. Now, our second speaker, Dr. Parthiban, is a senior consultant neurosurgeon from Kovai Medical Center in India. His expertise includes advanced spinal surgery, cerebral vascular and skull-based surgery, and he's also a great proponent of cisternostomy and a great teacher. I'm sure many of his residents will agree to this, and he's also here to share his experience and the technical nuances on the surgery. And also not forgetting Dr. Wang, our third speaker, who comes from Shaanxi, China. He's a professor of neurosurgery in the Shaanxi Hospital and also has practiced and published widely on cisternostomy in TBI. Now, without further ado, I'm going to pass the screen over to Iype, to Prof. Iype, to continue on with this presentation. Thank you.
Raghu, thank you very much. It's always a pleasure and honor to be sharing the screen with you guys. My good friends Parthi as well as Wang, it's an honor I would start by sharing my screen straight away. My thanks to Kanta and Hari, who are good friends, old friends. I hope you can see my screen. I hope you can see my screen, everybody.
Yes, yes.
Okay, right. So today we'll be talking on cisternostomy for TBI. This is a common scenario that you see all over the world. In fact, the most common scenario that you will see. And this is the consequence. The second image is, the first image is when things start going out of hand. And the last image is when things have already gone out of hand. And at this phase, a surgeon's worry would not be as to how to save this patient, but most of the guys will be thinking, how will I close this? So this happens all throughout. And this is, if I tell you, this is completely preventable, except in cases of ischemia. This is completely preventable with very good outcomes compared to this for if you learn some microneurosurgery. This is the point that I am going to talk about today. Why did DC stay for a century? So you must understand that trauma surgery is an emergency and it is unplanned. So a senior neurosurgeon wouldn't really like to go at 2 a.m. in the morning, put the microscope and do some skull-based work and open cisterns. And it's not just one case, in a large hospital, you may have up to 4 to 5 cases which may require cisternostomy. And can you imagine a senior neurosurgeon on call sitting and doing this and then going for the next day's elective cases? It's unimaginable. For a junior resident, a second year guy, you get to touch the brain, you get to see the brain. And that's a win-win situation for both the senior neurosurgeon as well as the junior resident. But the biggest winner are the companies who manufacture and sell cranioplasty to developing countries. These guys, I think this is the biggest silent business in the trauma, in the neurotrauma world, or maybe in the whole of neurosurgical world. And most journals are funded and supported by these companies. Vice versa is true too. And microsurgery is always kept as a costly option due to the monopoly of certain companies. When a microscope can be manufactured for less than $25,000, it would, of course, be sold at $500,000 or more. And these days, paper writing and statistics is promoted. You must understand that I'm not saying these two are bad, but if you don't know your surgery, paper writing and statistics is not for us as neurosurgeons. First, we need to know our surgery. It's very, very important. And then there are these big trauma surgeons, the Western lobby. I would not want to call out anybody because I have very good friends amongst this lobby too. But they are data collectors with hardly any skill. They don't go to cadaver labs. And that's now becoming a fashion. So all in all, it's an example of stupidity surviving despite we being aware of it. So this is why I would say DC survived for a century. The story of discovery of cisternostomy is nothing but a serendipity. I mistook a trauma brain for an aneurysm, and I started looking for the aneurysm. I mean, I wouldn't go deep into the story, but you must understand, I want you to all to make that calculated mistake. Think of your trauma as an aneurysm. Go to the base. If the aneurysm, if it's a bad grade aneurysm and the brain is swelling, would you do a decompressive? Would you try to open a large flap? Maybe 50 years before, but not anymore. You would want to go into the base and open the cisterns and let out the blood and then tackle the aneurysm. Here, you don't have to tackle the aneurysm. You are not worried that when you're retracting, there's an aneurysm which is going to burst. No, very, I mean, in our practice, that has never happened. Although theoretically it's possible, it has never happened. So I want you, just like me, to think that your trauma is an aneurysm. Get into the cisterns, wash out the blood. I mean, many guys have argued with me, no, one is trauma, one is aneurysm. It's the same subarachnoid blood. Traumatic, one is traumatic, one is aneurysmal. The only difference is that the aneurysmal subarachnoid blood stops immediately. The bleeding stops immediately because the CPP and CPP becomes zero, because the mean arterial pressure and the ICP becomes almost normal, almost equal, and the CPP becomes zero, and the patient suddenly, faints. And then what happens is the bleeding is there only for a few minutes or less than that, maybe a few seconds. But traumatic subarachnoid bleed is from the capillaries mostly, and it continues for some time. So therefore, a very bad subarachnoid bleed can only be equated to traumatic subarachnoid bleed. Now let's come to some cases, some old cases now. You can see this scan. You see the contusions and absolute lack of cisterns. Okay, this guy was M2. He was brought to us with M2, and it was brought to us. He was brought to us maybe in 2008, 2009. So this was in the beginning of our cisternostomy days. This was when I was in Manipal. So immediately after my Kerala job, I had gone to Nepal, and my first place. So this is the place where I was not really doing cisternostomy alone. I was doing cisternostomy with decompressive. So I had started putting back a small flap, a very thin flap. After the DC, I would do a complete temporal decompression and put the bone flap, which would be like a thin rim of bone. And you can see that in this guy's scan. You can see that thin rim of bone. If you see here, you can see that thin rim of bone starting there. Okay, but you see the difference. The difference is this cisterns. All the cisterns are open. The contusion is still there. We haven't really gone after that contusion. There are other contusions as well. If you notice, the name of this guy is Sanjay Upreti, and you can see. Huh? Upreti, pura naam kya hai? Bolo. This is the guy. His sutures have been just removed. And can you imagine, when you see this kind of results, how much ever the opposition is, you'd really want to push these kind of things, because you really don't want to miss out on treating these patients with a 100-year-old surgery like decompressive, which can at best put this young boy into a coma. So it's another scan. You see, and this is the result. Another one. You see how much is this midline shift. If he had any more midline shift, that midline will go out of his head. And you can see the herniation already. You can see the CP angle cistern is not only widened, you can see the herniation started here. The parahippocampal gyrus is started to herniate there. Okay, it's an acute subdural with a temporal contusion. So you see after cisternostomy, what has happened? Okay, this is the guy. These are our initial cases. Another case, acute subdural contusion, bone flap put back without any problem. Subdural is evacuated, bone flap put back. Another case, pretty bad one, absolutely no cisterns, subdural hematoma. This is what happened after the cisternostomy. You see this case. You can see the brain stem here. Can you see the brain stem? You can see those Duret's hemorrhages. You can see the brain is black. This patient, bilateral fixed dilated pupil, young female, E1, V1, M2. And you see that is a retraction injury because the brain came out like toothpaste. And so we had to retract the frontal lobe to get into the cisterns. You can see the drain there, and you can see her third nerve palsy while she's still in the ICU. And this is what she's like. Another one, pretty bad. You can see the brain stem rotated. And this is the guy after surgery. This is one after surgery. You can see the extensive injury, extensive damage here. You can see how the bone flap is sitting there without much issues. This is the guy in rehab. He answers a phone. You can, this is another one. Burst lobe, acute subdural. You can think about herniation, ipsilateral CP angle cistern widening. You can, whatever you can think of, it's there. It's a recipe for disaster with DZ. That is after cisternostomy. You can see the drain sitting there. And you must understand, these are not done by me even now. These are done by my boys. So this is the patient. Immediately after suture removal comes to my office, and this is how she is. And this is another one, acute subdural, just like the first picture that you saw. Okay, you must understand that if you remove acute subdurals, everything is okay. Usually 1 in 9 cases goes to very bad cerebral edema. 1 in 9. You don't know which is that 1 in 9. Okay, and many times acute subdural, if you evacuate, you may get away with it. You may put the bone flap, or you may not put the bone flap, but you may get away with it, you may not get away with it. But you do a cisternostomy, you get away with it. This is how post-op GCS, 15 by 15. And you can see this is GCS 9 by 15. Left pupil 4 millimeter, right 3 millimeter. You can see the burst lobes there, temporal and frontal. You see how bad injury this is. This is after cisternostomy. Okay, conducectomy, cisternostomy, no decompressive. Okay, patient was 10T, improved to 15 by 15. Okay, another one, burst lobe, contusions. Okay, everything. You see, this was a study we did, very interesting study where we studied the ICG for these patients. And well, this is another case done at a center near Delhi. This consultant opened this and he found this swelling. Of course, he didn't do a cisternostomy. I mean, he didn't put back the bone flap, but he said after this, he went into the base because he knew about our work. And he went into the base, and the brain swelling just completely came down. He didn't even evacuate the contusion. If you see, the contusion was not evacuated. And after the cisternostomy, the brain was lax, and the patient went home much better. Another one, okay? And the result, you can see how lax the brain is at the end of the surgery. This is from Czech Republic, just to show skin to skin was 65 minutes for cisternostomy, and ICP dropped from 48 to 11. Another one, see the midline shift, and see the acute subdural, see the blackish color of that same side lobe, see the impending herniation. This is after cisternostomy. Post-op first day extubated, obeying commands, done by junior consultants in my center. Another one, burst lobe. This is how after the cisternostomy it is. See the amount of space that is there in the pulsating brain. Another one, after the subdural is removed, cisternostomy is done, and you can see how lax everything is. So this is done by, again, my junior consultant, and you can see the whole basilar tree, everything. And you can see at closure. So this is, how does it work? It is a concept of CSF shift. You must understand that CSF shift is something that happens because the CSF in the cisterns are almost always communicating with the brain through the Virchow-Robin spaces. Why that happens is for cooling and cleaning of the brain. We will come to that later. But when there is subarachnoid hemorrhage in the cisterns due to trauma, that's a newcomer. The blood is a newcomer. And that newcomer comes with a lot of pressure. And the newcomer cannot shift into the Virchow-Robin spaces because Virchow-Robin spaces are very small and an RBC cannot go into them. So what shifts into the Virchow-Robin spaces is the fluid, that is CSF. And that is why you have, within 2 hours of trauma, you have only blood in the cisterns and all the fluid is shifted into the Virchow-Robin spaces. Imagine a Coke bottle, 2-liter Coke bottle. Try and inject 100 ml of 100 ml of normal saline into it. And can you imagine trying to inject into 2 liters, try to inject 100 ml of normal saline. You know, the pressures go up to unimaginable limits, unimaginable, okay? And that is exactly what happens if you put in a bar hole or something for these cases. I've seen guys trying to put a bar hole for an acute subdural, and the brain keeps coming out for 5 minutes. And they call it brain mushroom and stuff. But, you know, we have experimental evidence. This is the weight drop model done by Garnet Sutherland and Sanju Lama in Calgary. So we wanted to know whether they had a they had a 7 Tesla MR. And you can see the MR in the background. You can see Sanju sitting there with the mouse. They did a lot more study on this, but they wanted to know whether, as we proposed, CSF shift edema exists. If it existed, then within 2 hours, you would see water shifting into the brain and the cisterns full of subarachnoid blood. You can see in 15 minutes, the water shifting into the brain. T2-weighted hyperintensity is there. Whether it is blood or not, so they did a histopathological study and they saw the cisterns were full of blood and there was water in the Varsha-Robin spaces. The Varsha-Robin spaces were dilated, and there was water in the interstitial space even. And you can see that the first paper that came out showing that even moderate trauma, 2 Italian papers which came out, there was a paper stating that even in moderate trauma, not even severe trauma, moderate trauma, if you see, one of the major findings after 6 months is that all your Varsha-Robin spaces are dilated. So what about EBD? You can see on this side,
actually does so along.
You can see on this side, that is where they injected markers into the ventricle. That's where they injected markers into the cisterns. And you can see the difference. The cisterns, markers injected to the cisterns communicated with the brain very easily, while the markers from the ventricles, they did not communicate at all. Now, how is that important? How do you put a EVD and you get control of the intracranial pressure? That's because of compliance. When the pressure is very high, the compliance is very low, the pressure compliance curve is shooting up. And when you take out 2 ml of CSF, you're going to have really reduced pressure, because the pressure compliance curve is really shooting up. So it is on the other side, you take just 2 ml out, the pressure is going to come down. So you're playing just with compliance there, while when you're doing a cisternostomy, you literally allowing the cisterns to communicate with the brain. I mean, so those two are one compartment. So when you're taking this CSF out of the cisterns or taking the blood out of the cisterns, you're reversing this gradient.
Actually does so
this
along very
says
specific anatomical structures.
This was 2012.
There's specialized anatomy that allows the CSF to move very quickly and very deep into the brain, exchanging with the fluid that's inside the brain and then moving out. So it's a much more efficient system for clearing the fluid and the waste.
So you can see what I'm saying. That is cisternostomy. So that is the rationale. So when you have CSF shift edema, cisternostomy goes, what it does is we open here and there's a reversal of CSF pressure gradient, cisternal pressure gradient. On the other hand, if you do a decompressive hemicranectomy, this is what happens. That much, about 120 ml of brain herniates out. You can measure it. 120 ml of brain extrudes, herniates out through that deficit, and the ICP becomes normal because that brain is herniating out through the deficit. I mean, through that defect. And that's why the ICP becomes normal. But you look at the damage that happens to the brain because of this. It's almost criminal. It's a surgery which has survived, and it's, I wouldn't say, when I call out a lot of people and say it's criminal, I mean, that's because I'm radical, but it is not correct, you know. Now, a lot of people ask me, how do I get into the base of the brain in such a tight brain? That is why you should not be having a second-year resident doing this. If a second-year resident starts doing your basal-tip aneurysms or your bad-grade aneurysms, you can think about what all myths will start circulating about the malignant brain swelling and the brain fungus and the bomb explosions in ACOM aneurysms and so on and so forth. And that is why you should have experienced skull base and vascular surgeons starting to train these residents to do these surgeries. Otherwise, a second-year resident would not know his front side from his back side. So, I mean, he's going in there and you're throwing him to the, not only to the deep end of the pool, to the deep end of the pools with sharks and crocodiles. And that's what's going to happen to him. And then he sees this swelling. He would not have any idea of how to go to the base or how to do some skull-based work. And then you have scarred him for life. You're scarring him for life because you see that edema, and the next time he sees that kind of an edema, anytime in his neurosurgical career, he's going to have palpitations. So instead of that, you come to our hospital. Our residents are not really afraid of this kind of brain swelling. They immediately get into the base. When they see this kind of brain swelling, they know that they have to get into the base. And nothing is going to save them. And if you close this brain, or if you take out a little bit of frontal lobe without getting into the base, they know that they're going to ask for trouble. This patient is never going to survive. Well, you can, these are advanced videos of cutting orbitomeningeal band and how to get into the base in case of severe swelling, but I'm not going to go into that. I'm going to show you two very, very bad brain swellings, okay? I'm going to show you the first video. These are old videos, okay? And not done with me in the theater, but not exactly me operating. But you can see the brain coming out there. And you see how the brain's coming out. It's no problem, okay? I mean, see the opening. The opening is really small there. You're going in there, you're getting, retracting there. This is the real picture. It's not simple. It's not. It's a leap of faith to open small like that in such a really bad brain swelling. Okay, and put in patties and then go into the optic nerve and once. Oh, sorry. Huh. It seems these are on the YouTube, and you can see how the brain. I cannot control this for some reason. Is there any way that I can control this is what I'm thinking. Now I wanted to show you the end of it where this surgery, this is available on YouTube. You can see them and then you can see how the brain is lax at the end of the surgery. If anybody wants to see the video at the end, maybe we can spare 5 minutes because I'm running short of time. So these are the cisternostomy indication scores. One of the major indications is ipsilateral CP angle cistern widening. We made some obscene diagrams, but this explains it how, when it starts to herniate, how the CP angle cistern widens. Okay, so it's published. These are the pressures of our study, our publications from all over the world. Roy Daniels publications from Lausanne, Lorenzo's publications for the world, for the ACTA, and of course you have some of these criticisms. And the biggest criticism, for us was that you should excuse the residents because not all of them can do cisternostomy. That was the excuse. I think that is a pretty stupid excuse because it's like telling not everybody can do neurosurgery because most of us are farmers and therefore you can do neurosurgery the way farming is done. So, I don't think that is a pliable excuse. That's an excuse. That's an excuse of incompetence. And if a resident has to do trauma, he bloody well learned this. And he bloody well grabbed the skull base and vascular neurosurgeon who was in charge to the theater at least for 10, 15 times. I used to go to theater for every one of my cisternostomies till about four years back. I used to go for every one of them. And that's how my residents and my junior consultants got trained. And now I don't have to go at all because they're doing it. And I just have to see. I mean, if there is a real trouble, then I have to go in. But most of these days, these guys are pretty good. And you know what is a side effect? The side effect is that the boys are pretty good at clipping anterior circulation aneurysms and exposing posterior circulation aneurysms, because, you know, this is the same thing that they're doing. There's nothing different. If they see a little bit tight brain, they're not going to say, okay, let's close and let's do it another day. So this is cisternostomy on the Geno study, so that they haven't outlawed us now as it was before. So now it is an option to decrease the intracranial pressure. It is an option in Geno. So we are not outlawed anymore for the first 10 years. And this is something that Shabarish is going to do in United States. Shabarish is they're watching the webinar, I guess. And you know, after this, there's something that I have to tell you. When we figured that Varsha-Robin spaces, CSF is always going into Varsha-Robin spaces, we figured that there's something much more interesting to it. You see, our brain is cooled by the CSF that goes in almost every single minute. And how is it cooled? Because of our sinuses. The sinuses are lined with wet mucosa. It's like sitting under the fan with a sweaty shirt. If you're sweated and with your shirt on, if you're sitting underneath the fan, that sweat sock shirt is your mucosa. Imagine it's your mucosa, and breathing is your fan. And then your body gets cooled. That part gets cooled. That's the same way the sinuses are getting cooled. And this suprasellar cistern is right in the middle of all these sinuses. See the beautiful design that whoever, whether it's nature or God or whoever made this, evolution or whatever, whoever made this beautiful design, amazing design. And you see from the Varsha-Robin, through the Varsha-Robin spaces, all the vessels from the cisterns are passing into the brain. So these vessels are pulsating. And when they are pulsating, through the Archimedes screw principle, this CSF is being pumped into the Varsha-Robin space. It's being proven now. It's already proved now. But we hypothesized this, and we wrote a chapter in the Springer Neuro series about this way back in 2012 or something. And Intech Open is we've got a few more chapters and articles about the brain cooling and cleaning. And cleaning is when in the night you lie down and from the Varsha-Robin spaces, the aquaporin 4 channels open up, and then the CSF gets into the ISF of the brain and then cleans out all the chloride, lactate, and everything, byproducts. And that's why we have to sleep in the night, you see. That's why you should not be sitting up with your phones and everything. So that is cooling and cleaning. That is another perspective, that another beautiful side effect when we started exploring cisternostomy mechanisms. And well, this is our chapters. This is how the CSF gets pumped in. This is Voralak's illustration of how the brain gets cooled. These are our chapters in the Springer Neuro series. And this is in the Intech. And thank you very much. I apologize if I overshot the time. Thank you very much. I'll stop the sharing now.
Thank you, Iype. That was a great beginning to our webinar. A lot of interesting cases you highlighted. I'm sure there are going to be a lot of interesting questions at the end of the session. I think.
Yes, I'm waiting for that.
Now I think we'll move on to Dr. Parthiban.
Yeah. Yeah, I'm sharing my slides. Are you able to see this?
Yes.
Yes,
Are you
yes.
able to see my, okay. Yeah. Uh, yep, the basal cisternostomy, as Iype Cherian was talking about so far, is basically, people start talking as it's a very normal, very novel and CS of let out technique. Now, there has been a consideration about this particular term called novel um, because it was debated whether it is novel or something else. We all should appreciate one thing, that CS of let out is not a new procedure but old procedure. But looking at the lily quiz, it's novel in TBI. That is where it makes me more sense. But then still I like to call this as a microsurgical CS of let out technique. It looks like a more and a better nomenclature of the technique when we bring into this. And Iype has described this many times, that the trainees should get trained in microsurgery, and the trauma is the best place because you see it very often, where you can train yourself by seeing your teachers. So it's a pretty old technique, and Iype in 2006, postulated the use of cisternostomy in trauma, and gave some hypotheses, which is very interesting, and it makes you think a lot. But subsequently, in Roy in 2015, myself in 2016, and Wang in 2017, we all took it very seriously. Of this, though we were doing it earlier, but took very seriously and started performing cisternostomy in a very stage and stepwise matter in traumatic brain injury regularly. And we started presenting and publishing our results. Now, there are many surgeons started doing it. Probably the results may come in the coming days. So it was considered as a complex surgery. It demands the microsurgical skill and a great skill altogether. But people said it is not possible in all cases. Sometimes, yes, it is not possible, but it's not feasible practically in all places. Whether it can be done in a small setup without a microscope. But I personally feel it is still possible to an extent. So to make it more complex surgery in a simple way, we have to understand this anatomy, which you can go through is the theoretical part. And the very classical picture of this is the Lilliquist membrane, which separates the supratentorial and infratentorial CS of lacunis, that is the CS of where it is circulated around supratentorial and infratentorial. So as it was named that subarachnoid hemorrhage is everywhere and blocks the circulation, we have to open up these spaces and open the Lilliquist. Now, in a regular, if you're a regular surgeon and then you do the decompressive craniectomy and throw out the bone flap, and then you operate the patient again to put back the bone flap, provided your patient recovers very fast. And it is very difficult for a regular surgeon to retract the base of the brain in a very methodical way. But when you use microsurgery, it is better because you are basically a neurosurgeon. You have no choice. You have to be trained in microsurgery. And this you can see very beautiful pictures, which shows the basal cisterns and also the Lilliquist membrane. The Lilliquist membrane is nothing but an arachnoid membrane. So CS of cisternostomy is basically an arachnoid dissecting microsurgical technique, which is important for any aneurysm surgeon and for any tumor surgeon who are working at the base of the skull. So how close we can reach the basal cistern? Then if you have the lesser wing is being removed, you can see in this picture on the right side, you are very close to the basal cistern, and it is very easy to delock the lobes, as I was talking about. So it is very easy to go there. Lesser wing of sphenoid is very important in Cherian approach. Now, for the Malaysian guys and friends, we have seen, I was there in, when you look at your beautiful Petronas towers from front, it looks straight, two buildings, symmetrical and very beautiful. But if you go around the Petronas, and it looks different. I hope that you all understand this basic principle. It looks very beautiful. So the surgeon should get familiarized to see the basal cistern and liquids in many directions. So that is my important message here. I'm going to talk on surgical technique. Like you can see here, I'm not talking about how you remove the EDH or SDH or ICH, but how you reach the basal cistern. When you go from the frontal, you're straight, you need to do a bifrontal craniotomy or a small frontal craniotomy, then you reach the basal cistern from anterior. You go from Cherian, then you may have to tilt the patient's head to one side to 35 degrees or like over 45 degrees, and then like we do it for our aneurysm surgeries to open up the Sylvian cistern. That's the Cherian. And then the lateral position. So why do you want to change this thing? Is because when you have an associated clots, contusions, you may have to position the head in different format. So when you put it in a different format, you can remove both. And so you need to know how your systems look. For example, I'll show you this case. You have a right frontal ICH, which has increased in size. On the right side, you can see it is post-operative, completely removed and cisternostomy done. And I like to show you this very popular video. It is there in YouTube also. Right frontal contusion is removed. See, this is after ventilation. There's no retractor here. I'm using the cottonoids and retracting gently, and you can see the optic nerve. You can see the optic nerve. The arachnoid is gently pushed posteriorly. This is medial to the optic nerve. Dissect the arachnoid gently and keep on pouring saline, and cut the arachnoid meticulously without injuring any other structure. You see the pituitary stalk there. You can see the amount of subarachnoid hemorrhage which is coming out while you are doing this procedure. Now further dissection will give, you can see the anterior aspect of your optic chiasm. Now you come lateral to the optic nerve. You further dissect, peel this arachnoid. Basically it's a microsurgical technique. Lateral to the optic nerve, you can see the carotid artery. By teasing gently, you can see the optic nerve and carotid. This is through a bifrontal approach. That is your anterior. Now you see the liquids between these two windows. Open the liquids, you can see the basilar. Now, cisternostomy is made very simple here because it is a microsurgical procedure. Now, no need to get very much worried how I can reach, but believe me, if you prepare the brain very nicely, the technique becomes more simpler. So when you don't prepare it, that you do find it. So you have to ventilate the patient before you take it nicely, before the surgery, and see that you give the anti-inflammatories, whatever be the thing. And again, I can see in this procedure going into the interoptic. I try to dissect the arachnoid as much as possible when it is there. It's very important. How much? Because now in many places, very minimal is done. Like for example, you see only the carotid and the ICH. Then you remove there and then open up the CSF. It's enough. But sometimes I go a little overbound when it is very nice. I do quite a bit of aggressive washing. Now, by doing this, you find the brain is pretty lax. And so this is the basic cisternostomy through a bifrontal approach. That is through frontal approach. That is frontal. And as we do the anterior cranial base surgery. Subsequent to this, I like to come to the Cherian approach and slightly lateral and slightly lateral, about 35 to 40 degrees. This is a very classical picture of how do you do the frontotemporal craniotomy. You open up, Sylvian fissure has to be opened, but in the brain, when it is edematous, it is not possible to open so nicely. So you have to limit your opening. I'll show you. This is the Cherian approach. Now, this is a very classical picture. You can see the lesser wing sphenoid is excised after a large craniotomy here. And you may have to use the drill to take out the lesser wing of sphenoid and go as close to the anterior clinoid process is concerned. And I was showing how to remove these dural ridges, and then so dural has to be removed, cut, so that you relax and delock the frontal and the temporal lobes. So by doing this, you can get a very good closer approach to the cistern. Here you can see, very nicely, Here you can see the pictures shows through the Cherian approach. You can see on the right upper corner, you see the pointer between the optic nerve and the carotid, you see the Liliequist membrane. So the Liliequist membrane is open and you can place one drain there. So it looks pretty simple. It looks simple because it is done through microscope. Do through the microscope, it looks easier and easier. For example, a case like this, you can see is in the left frontal contusion, and there is some subdural, and there is pretty much a squashing. You can see the midline shift, the brainstem is compressed. On the right side, you can see after surgery, very nicely decompressed, and the bone is always replaced in most of the cases. This is the post-operative picture. Now, this is the operative picture, perioperative picture. Now, here, you have to just go back to the previous, imagine previous, the video. Now you see the optic nerve and the carotid system look slightly different because you are from a 30-40 degrees an angulation. So that is what I was comparing that with your Petronas tower. When you go from one side to another side, so your aim is to reach the optic nerve, and then you have much space to go lateral to the optic nerve and also lateral to the carotids. So that is very important. So when you go little lateral, you get lateral pictures. For more magnified view, you can see very beautifully, the chiasm is well exposed, the carotid is well seen. When you go lateral to see the right and the right upper picture, you can see the posterior clinoid here. In this particular case, the posterior clinoid was seen fractured. Such amount of force was there in this patient. And I am still able to see the Liliequist membrane. You can see the Liliequist membrane. You open the Liliequist membrane, then you can see the basilar artery. Down in the right lower picture is a classical microsurgical picture. When you see through microsurgery, it looks fantastic. It looks pretty fantastic. So how acute you do, it depends on how you do it, but then the technique is the same. We are microsurgeons, we are neurosurgeons. So when we use microsurgery, it looks pretty fine. Some cases come like this, like, temporal, there is a clot and there is a subdural. And on the right side, you can see the post-operative picture, very nicely done, and with the cisternostomy. And you find the cisterns are opening around the brainstem, and there is a very good result. Now, this can be done absolutely on the lateral position. So sometimes I put the patient, depending on this clot, I put the patients like this. Now you can see here something more lateral, and you see the angulation that the maxillary comes up laterally so that the frontal lobe falls back. When the frontal lobe falls back, your retraction is pretty less. Many people used to ask, how will you retract? Yeah, because many of these, the regular surgeons, regular neurosurgeons, they put the position and it is flexed. So when you flex, when you do the craniotomy, your brain, the frontal brain is more going towards the floor. So you find difficult to retract. Now, you have to think that you're doing a aneurysm surgery. You have to respect head injury patients. As you respect an aneurysm surgery, you respect the aneurysm, respect the trauma patient. Then you put the patient on this position, and then you start doing the surgery. It comes out well. You look at this brain looks a little bit pale. Look at the angle of the optic nerve and the carotid. You see in a different angle. Am I correct? I hope the audience who are looking at that can see. In whichever way you go, you have to reach the liliquist. That's the beauty. So if you want to reach the liliquist when you see from in front, it is strike the scene between the optic nerve and the carotid, or just lateral to the carotid and the third nerve, you see the liliquist. But when you go to Cherianal and then you go to lateral, you find it because the angulation is a little difficult. So you may end up, so you have to do a microsurgical maneuvers to, you can see the tube which is coming on the right upper and the right lower pictures. You can see the drain tube which is coming lateral to the chiasm. I hope that you can appreciate between the carotid artery and the chiasm. So this is an excellent way of a microsurgical demonstration of cisternostomy. In this, you can see on the left quadrant and the lower side, it's a video running there, and you can see that I'm just explaining the area. After removing the cottonoid, you can see the drain path. This is one more video I like to show. The idea of showing these videos is for the young surgeons to find that this is more on the lateral approach. When you see on the lateral approach, it is more or less more than the Cherian approach. This is slightly, it's not a normal speed, it's slightly faster. Don't think that I'm doing surgery very fast. Now here, the speed is doubled because of the time concern, and the temporal lobe is not retracted. Please notice this important point. The temporal lobe is not retracted, and the microscope shifted from the posterior to anterior and angle. You can see that it's just watch the microscope moving. So it keeps moving from, say, after seeing the optic, now I've come to the lateral to the chiasm. You can see the A1 there, and then the cottonoids are lateral to the carotid there. And then you see the PEC, that is the posterior clinoid there. Yeah, you can remove this. So those are the liliquist membranes start coming up. There are quite a bit of arachnoids. You start gently teasing those arachnoids. You see the Cs so keep on oozing from the infratentorial and also supratentorial subarachnoid spaces. So it is a very, very, basically, I'm repeating this, a microsurgical technique. So you must get trained in microsurgical technique wherein you operate through a small area. So that's more important. This is a faster video, so consider that. And the temporal lobe is not retracted. This is what you retract to the posterior aspect of the frontal lobe. And here I'm trying to go medial to the optic now. Now see, after the decompression, after the cisternostomy, you can see the brain is lax. The brain is pretty much lax there. It's very important. Now I skip this video because I've already shown. Now you see the left upper quadrant, you see the decompressive craniotomy, massive cerebral edema. There's a huge decompression done, but is it really necessary? That is the question. Then after the cisternostomy, it is pretty lax, and you put back the bone flap. Now many people will ask, do you need to remove the bone flap or not? From the initial cases, we were removing all the bone flap, and then we replaced the bone flap, and then we learned over a period of time that such a massive bone flap removal is not necessary. Such a big craniotomy is not necessary, absolutely. And so then we can bring down what we can do, the smaller the craniotomy. I have to thank Warlux for helping me. She has given a very nice pictures of describing this large craniotomy, and then you do cisternostomy, and then put back the bone. But then now this is a large craniotomy and cisternostomy. So how do you do the smaller frontotemporal craniotomy and cisternostomy? You can still open smaller like a frontotemporal Cherian approach. You don't need to open completely, and then you can expose only that part of the brain which is required to enter into the cisterns if you don't have any other clot or this one to evac. Many of the subdural, they just come out. You do hydrodissection. You all know pretty well, you are very trained for hydrodissection. Push with saline, it comes out. You can see here, very nice frontotemporal. It's a small craniotomy, well done, and the midline shift has come down, and the first postoperative. and also 5th postoperative day. I'll show you this video. You can see that you make a small craniotomy, and then this dura is not open. We keep this dura there because so that the brain does not bulge out at the initial stage when you open it, like what you saw in the previously. So we graduate our knowledge and then we reduce the opening. Still more reduction can be done. And now you watch here, the brain is pretty lax after cisternostomy. You can see here, so lax. So now, not very sure about all cases we get it, but then many cases we can do that. And this is hydrodissection. I keep doing the hydrodissection. I keep doing the hydrodissection. You can see the frontal lobe is moving very nicely, pulsating. And this itself will tell you that this patient will do very well. You can see here very nicely. You appreciate this case, and this is the case. You can see here frontal and then decompression done. About this, I think Wang will talk about next to me. The ICP, we start using the ICP monitor routinely. You can see there's a burr hole on the posterior aspect. The arrow says, arrow is showing on the left upper picture. We have a separate burr hole for ICP monitors to go in, ICP probe to go in, and that gives that before you have about 29 to 30, 35. Before intubation, it was 40. After intubation, and there is after ventilation down, and then after cisternostomy it is 5. So this can be maintained in the postoperative period very rarely, and the numbers are less, though we have to say about pediatric. In pediatric cases, patients always used to ask, how can you do a cisternostomy in pediatric? It is possible. The anatomy is much different, but it is difficult, but it can be done. This is one such case I'm showing you. You can see on the left side, the craniotomy done, the dura is less open, cisternostomy done, and then the bone flap is replaced. This is the case of finding. You can see subdural, massive edema, and very massive edema on the second 6 hours later on ventilation. You can see that. And then surgical decompression, more than surgical decompression, SDH is removed and a cisternostomy done. This patient took a long time for recovery, but the child is doing very well. Now, to conclude my talk, I have to tell you one thing very clearly. This is very important to assess ourselves. And I'm not going to talk much about what was the past, and I like to say about what is the future. The future is, one thing is that CSF let out. The CSF let out is now being introduced as a separate chapter in the Brain Trauma Foundation, the 4th edition. We all know about it. It is being introduced as a separate chapter by as accepting CSF let out as an important thing in reducing the ICP. But from where you let out the CSF is more important. Now, whether it is going to be from the ventriculostomy or from basal cisternostomy. I have a feeling that this group of surgeons with Iype's heading up in the last decade, in future times, and then you guys all will start doing it. Thank you very much for listening. Thank you. Thank you.
Thank you, Dr. Parthiban. Thank you. That was a very technically sound and helpful segment of the talk. And now we move on to our third speaker, Dr. Wang. So Dr. Wang will be talking about the use of ICP monitoring and how concurrently they can augment the cisternostomy as a technique. So I'm going to pass it to Dr. Wang. Coming to the panel soon. We seem to have a lot of questions already being submitted. So I think we're going to keep the panel here a while after Dr. Wang ends, just to answer these questions.
Okay.
Hi, Dr. Wang.
Thank you for your invitation to this webinar presentation. It's my pleasure. I will have a lecture about pathophysiology of cystostomy. I'm from Iype Hospital at the Chinese Yongman province, a very biggest hospital. At the Yongman Center, we have a lot of pre-trauma surgery, aneurysm at the pre-hemorrhage. Actually, I do cystostomy all my emergency surgery, such as pre-trauma, pre-hemorrhage, and pre-aneurysm. And I recently, I think most of the bone will will replaced. So after cystostomy. And I will show the history of cystostomy. Actually, the cystostomy have more than many years ago. This is the oldest paper about in 1979. And this paper report about cystostomy. Actually, cystostomy had opened the ambient system and then drainage. Actually, this surgery is oldest cystostomy. So we open the cut temporal lobe
Wang,
until we get.
Wang, that paper is not being seen. Your only one screen is being seen. Your collection of papers. That's all being seen.
Mm-hmm. So if the ICP is very, very high, we can use this technique and open the ambient system at the drainage at this time as the ICP will down. And this is also 1979 paper about aneurysm, ruptured aneurysm. This is paper from Japan and use basal cyst drainage and lumbar subarachnoid line drainage. So use basal cyst drainage, we can restore the CSF circulation to normal and clean the CSF blood around the ring of Willis follow SH. It prevents and cures the postoperative vessel spasm which may occur. So it's very good for aneurysm. So we and now I use cystostomy and basal cyst drainage in every aneurysm patient. And this is Chinese expert Professor Go at use cystostomy in the pre-trauma. So this paper have reported 22 patients in neurotrauma. And after surgery, this he drainage for about 1 week, and they can reduce reduce ICP and decrease brainstem and reduce hydrocephalus. And usually he use 4 days or to 10 days drainage time, and usually about 10 centimeters high, before higher than frontal echo. And it is very important to the drainage draw. This is
I have to interrupt you for a second. Your slides are not visible on the screen. The slides are not coming up on the screen, the share screen.
Oh, sorry.
Yeah, your slides are not coming up on the share screen.
This is Dr. Iype's paper about the cystostomy for traumatic brain injury. At this paper, they introduce how to do the surgery at the surgical technique note and the pathophysiological mechanism This is
Dr. Wang, the screen is not coming up yet. Sorry, the screen is not coming up. You need to share it again. I'm so sorry. Your slides are not visible. Maybe you can unshare and reshare it again.
we share again.
Yeah, we are not seeing the screen. We are not seeing your presentation on the screen. Yeah, we're not seeing the slides, your slides.
We not see. Do you see?
Not yet. Ah, yes, only now. Yeah, only now. Yes.
Only now.
Yeah, you can mix to. Okay. Yes, better.
Okay. Okay.
Right.
This is a paper, Cisternostomy for traumatic brain injury. This is read by Dr. Iype Cherian, and he introduced surgical technique note and pathophysiology mechanism. And this is from Italy's paper, and structomy and extensive cystostomy CSF drain for acute management of malignant middle cerebral artery infarction. This is actually he used a small cut at the open at the cut the temporal lobe at the use cystostomy. So we can use a small cut at a small bone. So actually, I use cystostomy in infarction, cerebral infarctions. It's very good. Actually, because this paper have filed the pathology of cystostomy, and we have for the perivascular pathway at this facility CSF from fluid breaking and clean the interstitial route. And this sorry. Do you see this slide? This we have lymphatic pathway have wide very wide pathway for fluid transport in mice, which include the arterial influx of subarachnoid CSF into brain interstitium. The interstitial backflow between the influx and efflux pathways depend on extracytic water movement. This is our this system be called the lymphatic pathway. Actually, in our human brain, we also have found there's a very wide lymphatic enhancement and clearance in human. This is brain we can see use MRI different time work lymphatic pathway in human brain. And actually, the current pathway recognized for the exchange of fluid within the intracranial compartment. According to new hypothesis, the fluid exchange between the system and the brachium through the perivascular virtual rubber space may be of great importance than the traditional recognized transfer fluid within the ventricle system and its absorption at the level of sinus. So we can see CSF from ventricle system to system and the venous system. So because between the system and the brachium, this by directions. This is CSF shift edema. because the subarachnoid hemorrhage in trauma reaches the pressure over sisters. At this time, the CSF follow the perivascular and into the pericardium and driven by the pressure gradient through a ventricular space into the brain. And we use the cisternostomy and reduce the pressure of sisters and reduce the brain edema.
Dr. Wang, sorry, your slides have stopped again. I think you need to just reshare them.
So Richard?
Yeah, it becomes static again.
Sorry. How about this one?
1 second. Yeah, I think you can put it into slide mode, presentation mode,
How about this slide?
Yeah, it's moving. You can put it in the slideshow mode, so there's a full screen.
Oh, this is a paper about the perivascular pathway for influx of CSF most efficient in the middle brain. This paper is different time in middle brain CSF CSF. So it's very efficient in the middle brain CSF fluid, are the most efficient in the middle brain. So this is a time active curve of the middle brain at the front lobe. Within the first 20 minutes, there was high centigrade of DTPA in the middle brain compared with the front lobe. Actually, biomarkers of traumatic brain injury are transported from burn to blood vessels via the lymphatic system. There's 4 unique approaches to suppress the lymphatic associated clearance. Alpha-4 dilation, cisternostomy, and sleep deprivation. Suppress of lymphatic clearance prohibit the delivery of TBI by marks to the serum. Cerebral spinal fluid influx drives the acute ischemic tissue swelling. So this is our sorry. This video cannot. This video cannot open. Sorry. Could you see this slide? Sorry. This is this year's paper in Science about cerebral fluid influx drives the acute ischemic tissue swelling. This is after pre-infarction, the middle brain as the cerebral artery, the artery, the perivascular space is large, and thus weak the brain edema formed. This is after craniectomy lead to impaired lymphatic flow, decrease arterial pulsatility. Craniectomy leads to bilateral decreased cerebral penetrating arterial pulsatility. Craniectomy results in immediate impairment of lymphatic CSF influx into the brain. Craniectomy results in prolonged failure of lymphatic CS influx into brain, and also prolonged failure of lymphatic CSF into the brain during 40 days, 38 days, 56 days, and also impaired lymphatic CSF influx immediately followed decreasing craniectomy and lasts out to a port between 40 and 38 days following depression, regardless of whether craniectomy is performed. So it's impaired brain function. And craniectomy also induce extra glial activation, increase and induce microglia activation, and impaired object memory and coordinate movement. The y-axis represents the latency to fall for the rotatory assessment and the percentage of time spent with a normal object for normal object recognize test. So this after decreasing craniectomy also impairs animals' memory and objective memory and coordinate movement. This is a microcirculation of our CSF. The lymphatic drainage and the cavetic influx lymphatic over the brain. At the top of the figure, the artery is lined by endothelium and coated by the tonical medium, composed of smooth muscle cells, and by the outermost tunica adventure, composed of connective tissue. At the arterial divided into capillaries, the tunica media and the layer of the pear mate are lost. This is microcirculation over the CSF. This which is the connective influx lymphatic pathway, and this is CSF at the brain allows the pear glial basement memory between the pyramid and the glia emitters. And this this is a diagram to illustrate the possible mechanism by which immunocomplex disrupt the perivascular drainage of the throat. So after the brain trauma and brain aneurysm, the drainage of soluble dextrose is blocked by immunocomplexes. So such as many patients in trauma and brain aneurysm have hydrocephalus. This is microcirculation of CSF, and this is structure of the microcirculation of our sister CSF. There's endothelia, basal memory, and this is perivascular space, and there's circulation, CSF circulation. This is the structure of CSF microcirculation circulation. This is my PowerPoint of my lectures about cisternostomy pathophysiology. Thank you for your attention.
Thank you, Dr. Wang, for your detailed analysis of the ultrastructural and chemical changes that support the concept of cysternostomy. And now I think in the section that everybody is waiting for, we have a lot of questions being put forward by the floor. So I think if the panelists are all ready, then we can proceed.
Yep.
Yep. So
I'm here.
all right. So I will begin with the first question since we are running short a little bit of time. Now, in the some of your early slides, right, you mentioned about the indications for doing this, subdural, midline shift. But I noticed that in some of the cases that you highlighted, the patients had dilated pupils and even posterior fossa pathology. So rather than asking you, when do you do a cysternostomy, I'm going to ask you, when do you not do? When is it not a good idea to do it? Yeah.
Yeah, so this is something that we figured out after a long time. Because initially, I would have done it for even, piles. I would say that even if a patient came to me with piles or hemorrhoids, I would say, okay, do cysternostomy, it would get well. But later on, we understood that not all head injuries will respond to cysternostomy. So, especially when you have dilated pupils, when you have a motor score of 2 or 1, or if you have clear evidence on the CT for ischemia, these are the times, or combined, or these combined, or one by one, or maybe two at a time is not a good indication for cysternostomy. Because if you do, then it is very unlikely that the brain is going to go down, because it's ischemic brain, and then these patients are not going to do very well. I have seen that you have to keep the flap out to give them any chance. So this is the time. Otherwise, that said, we've had some dilated pupils. I have a guy who's still walking around with dilated pupils. So there's a lot of cases that we see which are pretty bad and they improve, but that doesn't mean that all of our cases do that. Obviously, I have put up my best cases.
So I suppose conventional wisdom will prevail in these circumstances.
Absolutely. Common sense.
Sure. Okay. I think now move on to the subsequent question. Now, some of our attendees are very curious to know the sort of drain that you will use. Now, I personally remember, you had put in cisternal drains, as part of your procedure to continuously drain CSF out. And then I think in some of your publications, you've even spoken about just wide dural opening and letting the CSF fill into the subgaleal space. So perhaps for our attendees, what sort of drain would you place for the cysternostomy?
See, in the very beginning, we started putting the drains, and then we had some bad experience in 2008, 2009, where we had ventriculitis and severe infection. So we stopped putting the draining. But that was only for 1 year or 2 years, and then we figured out that if the drain is not put, the whole cysternostomy usefulness is not really reached. So we started putting the drain again. So what we put is feeding tube number 8. And we put it, it's a rigid structure, nothing will happen. You put the feeding tube number 8 into the opticocarotid triangle or the lateral carotid triangle. You put it past the membrane of Lilliquist into the prepondine cistern. You keep the drain, you keep the bag at the bed level for the first day. Usually it's on the night, so till the blood clears, you have to put it on the bed level. And after the CSF is clear, you need to raise it to 15 centimeter. If you don't do it, over drainage is also equally harmful. Over drainage produces something like a paradoxical edema. And it may not be with high ICP, but the brain looks extremely swollen and these patients can deteriorate. So since you've asked about the drain, this is our experience. So first day, put it down on the bed, and from the second day onwards, raise it to 15. And if the first day the blood is not yet cleared, we can still put it on the bed level. And when the CSF is clearing, starting to clear, you can put it up. You can put it onto the 15 centimeter height.
Okay, thank you. Now I just open this question to everyone. I mean, we have a lot of young residents and people who are starting out doing cisternostomy in our group here. And of course, in an ideal situation, everybody wants to put that bone back. But being hardwired with the principle of decompressive craniectomy, it is not easy to make that leap of faith. So some of our questions that they have posed is, okay, number one, how do you have a way of deciding which one you'll put the bone flap in? And I think a subsequent question to that is, what do you do if after you've done a cisternostomy, you've opened up the systems, you've drained everything, the brain does not reduce, the swelling does not reduce? And I think another related question is, have you ever had a situation where you drain the CSF, brain was relaxed, you put the bone back, but you had to go back in after 24 or 48 hours to remove the bone flap? I think these are interrelated questions. Dr. Parthiban, Dr. Wang, we're happy to hear all your experiences.
Yeah, I will tell my experience. So this is in my beginning of my series. I mean, almost, in fact, 300 cases we did just decompressive and cisternostomy together, which means we didn't put the bone flap back. So that was because there was nobody to support me. And if I had a problem, I mean, things where people are not going to be kind, because I was, people had not even heard about cisternostomy at that time. So almost for 300 cases, we didn't put the bone flap back. We had and then we started putting the bone flap back, but with a very thin rim. We took out a lot of temporal bone. We bit out a lot of temporal bone and put the rest of the bone back. That's how we used to do it. And after we started opening membrane of reliquest, the number of times that I have to go into theater to take out the bone flap drastically reduced. I mean, now it is almost nil. We don't see that. But yes, all this is part of the game. The most important thing is to start. When you start, there will be failures. It's like asking aneurysm surgery. Is every aneurysm surgery a success? No, obviously not. There are times when you have to go back into theater. There are times when you have to, do a decompressive later on. So yes, but as your expertise improves, the results also improves. Okay, that is my answer to this. I'm sure Parthiban and Wang will agree to this. I mean, I would like to hear their versions also. And as far as wouldn't you do, the second question I didn't get. The second question was about
when, like, if the brain was swollen after you've done all these procedures, what else can you do? Maybe put a lumbar or
immediately. If the brain, see, this is not to convince anybody. If the brain is not lax, don't put the bone flap back. This is for sure. This is not, this is cisternostomy or whatever surgery it is for the patient. It is not for a protocol or anything. If the brain is not lax, don't put the bone flap back, but immediately go take a CT, because a CT will show that probably there is an extradural on the other side. We have seen that. Probably there is blooming of a condition on the other side. We have seen that. Probably there is a contusion or a bleeding on the same side in the base. We have seen that also. So immediately, don't put the bone flap back. Don't throw the bone as well. Immediately send the patient for a CT after closing. And then after that, if there is a pathology, deal with it, put the bone flap back.
Yep.
Dr. Parthiban?
Yeah. I also agree similarly, but initially we were doing the large, you saw my pictures. Initially it's a pretty large because, what if the let out is not going to? What I found as I was talking about, after doing many cases, you can replace your bone in most of the cases. There is one important point, outcome point here is that after a good cisternostomy, if the brain is going to be very, very large and there is no other new hematomas which are formed, like I was talking, then those patients will have a very poor prognosis. Very poor prognosis. You do not expect them to survive. That's my personal experience. In fact, that I was not able to show that picture. It was coming in the next slide because I just restricted my talk up to the technical aspect. There are conditions we come across, we open up because acute cerebral edema, you open up. The brain just pops out. That's the reason we do not open the dura now much more. We restrict the dura, don't open it, make a small dural opening, go to the base and let out the CSF. And once you let out the CSF, you observe the cerebral edema. And if it is going to go down, then you don't need to put back. So you just need to do only hydrodissection. A good hydrodissection will wash out the extra subdural hematomas here and there, and also very good CSF later. Now, the point which I was talking about is that this is a very important point, is that this also makes us to think that the DC is really helping in severe head injuries. That we throw out the ball, they don't do well. They have a very poor prognosis. They either die on the first week or something like that, and they do stay as very, very unconscious and moribund stage in the post-operative. We do not give a real quality of life to those patients. So this point, I take it as prognostication also. So it made me to mature, like what I was telling about that small rim is actually he was doing a floating bone flap technique, something like that, you know. So even when we were taking a large bone flap, we put back sometimes, and you believe me, after some time, you know, it settles down. Now so these points are very, you start doing it, you start enjoying that, and you start accepting it. For example, like you said, Dr. Raghu said very nicely, you are a decompressive craniectomy surgeon so far. We were all doing it earlier. Now, when you start doing it, immediately you start, doing with a small opening. You may have that in the back of your mind. You are very scared. What happens if the brain bulges? Don't get worried about. Nothing happens. This is the experience we gain after doing at least minimum 50 cases of cisternostomy. So now the teachers have increased. So earlier only Iype was talking. Now in the past few years, there are more experienced surgeons like Wang and so many, Roy, and so many others are now doing it. They start realizing that it is not necessary. So we can judge the outcome also when we do cisternostomy. That's my point here.
Thank you, Dr. Parthiban. I think that's a very good point you have highlighted. I mean, if all else fails, including cisternostomy, then the prognosis is going to be very clouded. Yeah. Okay, we have another question here with regards to alternates to the pre-pontine drain. I mean, one is, can you use a EVD, or do you regularly? I think you do regularly use a EVD from what I've seen in your presentation. And one of the audience members wants to know whether there's a role for a lumbar drain as an alternative to, to draw out CSF. So, I mean, I know this is a point of contention, definitely, but we'd like to hear from the panel. What do you all think?
Well, I don't put an EVD. And if your cisternal drain is not working, I would rather go back in and put in the drain back. So I would not resort to lumbar or EVD or anything. It's 5-minute thing. It's just going in, putting back that cisternal drain in. I mean, also this used to happen in the initial stage. Even when my boys started doing it, there were cases when the cisternal drain was displaced. But you see, the pre-pontine cistern is such a space that anteriorly you have the clivus that's not going to move, and posteriorly you have the pons that's also not going to move. So you have a space there, and that space is going to be fixed. So that's always going to drain CSF. So it is not usual that the CSF drain gets blocked, and especially that rigid tube, the number 8 tube, generally does not get blocked. So if you put it into the pre-pontine cistern, you will keep on draining CSF. And I have never done a lumbar drain or EVD. Neither do we start mannitol for these cases. So that is also one thing. Our unit may be the only unit in neurosurgery where you don't use mannitol at all.
Dr. Pathi, anything you would like to add as well?
Yeah, I'm just also thinking about some of the points, that like you say that, after letting out so much of CSF, do you really need mannitol? These are the points which we really have to rethink, because there are a lot of points Iype is making because of the large experience which he had in this trauma surgery. It has to be taken very seriously. Like I said about this, in spite of good cisternostomy, in spite that you are able to reduce whatever CSF which is coming from, and if the brain is still bulging and coming out, they don't do well. They don't do well at all. Now, similarly, the point which is making is, do you really need, when we do a good cisternostomy, do you really need a mannitol to act on that? If it is there, where it is to act. So it is a point to be thought, and I'm also learning a lot when I keep telling about some points. We started thinking about like the drain which is kept at the, I usually used to keep at the same level or lower down. Now I'm also thinking about now rethinking, should I keep it lower down or keep it at the same level and then take it up? So it is where we learn and relearn. And so this is the process. When I was talking about it, there is a group which always say no to cisternostomy. Okay, then no problem. Just people who wanted to keep telling, let it keep. But if you wanted to learn, you have to listen and then relearn. That's all. So that's my view. So I learned some of the points, every day when I talk with, when Wang showed few videos. He showed a small dural opening, very small dural opening, and I've showed another pictures where there are so many multiple contusions. You don't need to go and chase the contusions. You do a good cisternostomy, it will take care. The peri-contusional edema. Now, so if it is a large contusion, yes, you can excise it, like you do for a SDH. You can excise it. If it is a large contusion, like I showed in my case. But if it is small contusion here and there, you cannot chase them. The cisternostomy becomes. So these are the points we keep learning. And these are not addressed in the previous generation. The DC never addressed all these things. We just open it. I have done so many DCs. Like Raghunath was talking about, that it is not a new procedure. And all bifrontal craniotomies in those days, we used to do cisternostomy. Like opticocarotid is open, let out the CSF, allow the frontal lobe to settle down, and then put a facial letograft for the frontal bone fractures, cranial fractures. So it was a routine procedure. So on keep doing it, I think we learn a lot. Yeah.
So okay, thank you, Dr. Parthiban. I mean, on that note, see, after in the post-operative management of TBI, and if you follow the standard protocols, there's a lot of ICP and guideline-driven, protocol-driven management algorithms. But here, in like what Iype is saying, you don't really put in, you just put in a cisternal drain. You're not really monitoring ICP. Then the issue of mannitol. So do you go according to the CT scan, or how would you make the decision to de-escalation of sedation and therapy? How do you make those decisions in this setting?
It's a question for you. The voice was.
You're muted.
Mute.
Sorry. If you see the New England Journal a few years back, there was a study which showed that there was no need for ICP. And if you don't see the cisterns, no single cistern is seen, your ICP is definitely about 25. And if you're seeing cisterns, if you're seeing all the cisterns, your ICP is definitely low. So you have to go by common sense. You cannot just go by whatever these guys have written. You know, one of the things you have to understand is that most of these studies derive their data from surgeons who are second-year residents. Most of these trauma surgeons who are presenting their data, like in DECRA or the British trials, these guys are mostly data collectors. They are sitting in and collecting data, which the most junior guys are doing. Imagine collecting data from the second-year residents on complex spine surgery or on aneurysm surgery. What will the data look like? It'll be terrible. So it is actually, I mean, I don't think that we are living with the right kind of data right now. I mean, things are really blown up, and it is to everybody's advantage. Things are really blown up about the malignant brain swelling, about mannitol, about all these ICU management, because in the West, it is the ICU guys who are looking after this trauma neurosurgery. It is ICU guys, which is, again, I say it's very wrong, because this is something that the neurosurgeon has to look after. And right now, most of my friends in the West say that, listen, the management is done by the ICU guy. Where does the ICU guy come in management of brain trauma? When do you go for surgery? When do you not go for surgery? And do as I say. This is all nonsense. We should be telling the ICU guy, listen, this is the time I have to go in for surgery. You manage my patient and I'll do the surgery. So a lot of wrong things are passed under the bridge for trauma. And it's time for us to correct it. It's because if we don't correct it, our young neurosurgeons are going to go for fellowships for skull base and vascular and all these things, and they still continue to do DC. Because if they do good skull base, this is the starting. If they do good skull base and vascular, this is the beginning. This is the largest number of caseload you have. Do some mistakes. Anyway, you're doing DC. That is the biggest mistake. So do some mistakes, no problem. But in the end, figure out how to get into the cisterns and how to manage this so-called malignant brain swelling. Instead of using mannitol, obeying an ICU consultant. Of course, you can obey an ICU consultant when it is non-operative. But otherwise, if it's an operative case, why should you listen to an ICU consultant who doesn't know ABC of what is surgery? So manage with the ICU consultant. You don't need to disrespect them, but you need to be very clear. You need to tell them, listen, boss, this is my call. I am going to take this patient up for surgery, and I'm not going to wait till the patient is cooked. And if you ask for data, you know, what is the best way of stalling something? This is a political move, to ask for a data, to ask for an RCT, because it will go on for 10 years more. And that is why no development has happened. How many neurosurgeries, including aneurysm surgeries, drill, CUSA, how many of them have been accepted after RCT? I'm asking you, was DC accepted after RCT? Only after this RCT and this trial culture has begun. You see, neurosurgery in the last 30 years, where are we? People who are 30 years before has much, much more skill than the present day young generation, because the present day generation believes in RCTs and papers and not neurosurgery. We like professional athletes. We like professional footballers or professional race car drivers. We cannot be sitting and writing papers. If Ronaldo or Messi or Schumacher or any of those guys, do they sit and write papers? No, they don't. We need skill. And the only way skill can be obtained is go to the theater, go to the cadaver lab, practice surgery. And if you don't want to be a neurosurgeon, be a data collector. Don't put yourself as a neurosurgeon. Then be a data collector. Say that you are practicing neuroscience or neurostatistics or something. I mean, this I am very clear about. I've been attacking these kind of people, this lobby from the beginning. So neurotrauma is really blown up. It's saying, oh, malignant brain swelling. What do we do? I'm telling you, it's very simple. In aneurysm surgery, do you ask these kind of things? No. Raghu, you have seen this. You should tell your residents. I've seen your videos. They're beautiful. So what I want you to do is tell your residents, be with your residents, teach them how to open the system. That's what Parthiban is seeing. Parthiban is as senior as my teachers in Vellore. So for that man to take up something like cisternostomy and make a complete U-turn is something that we all should learn from. I am telling you, if I was at his seniority and as established as he was, then a young Turk comes and says something, maybe I don't know whether I would have accepted it. I would have said, you're talking nonsense. It wouldn't work because it's my experience. So that is what he says. What is our experience? So today, if somebody says something new, I was always listen to them. And I'll say, okay, I'll try my level best to emulate, see whether it works or not. Well, if it doesn't work, it doesn't work, okay? It doesn't work. But when all of us are saying, and this has been done many times before, this is being done for aneurysm surgery, this is being done for tumor surgery, why can't you do it for trauma surgery? And why can't you train your residents for trauma surgery so that they learn microsurgery instead of going to the West in the United States and standing there for 1 year like a peon, looking at what the other guy is doing instead of figuring out what is skull base or what is vascular on their own when they have such high loads of trauma. That's my question.
Thank you, Iype. Thank you, Iype. I need to push us forward with a few more questions. Some of the panel, participants want to know, what are your thoughts, especially this is for Dr. Wang and Dr. Parthiban as well, because he has highlighted, Dr. Wang has highlighted in his presentation about the role of cisternostomy in conditions like malignant middle cerebral artery territory infarctions. So perhaps a brief one on what you think about that.
I don't have experience on this. I don't have, I have done about 12 cases and most of them I had to go back and, go back again. So the neurologist himself stopped giving me that option of doing that. That's why probably I don't have an option, but yes, Wang says it works. Obviously, I'll have to try this again, but I don't have much of an experience. Maybe Wang and Parthiban should talk.
Dr. Wang?
Wang,
Yeah.
Wang would like to say about infarcts, middle cerebral artery infarcts, and the utility of cisternostomy.
Sorry?
Wang?
Yeah.
Infarction, middle cerebral artery infarcts. Ischemia.
Sorry, your phone?
Are you able to middle cerebral artery ischemia, infarcts, and cisternostomy?
Actually, yeah, my system for yes. And before surgery, I will use ICP monitor. Every patient I will use ICP monitor. Actually, in my experience, if ICP is more than 60 millimeter mercury, there is no use, declaration no use, system no use. Because in my group, this patient before.
You're not able to listen. Yeah. Are you able to listen? I'm not able to. Wang?
Seem to have lost him.
Oh. Okay. I think he's there. I think, but we lost his connection. But as far as the, yeah, he's there. Yeah. Wang, unmute. Wang, unmute.
Yes. So because the internet is not a good signal, and as if the ICP is high, very high, more than 60 millimeter mercury, there's no use. Decreasing DC is no use at the cisternostomy because at this time CSF is not too much, so we cannot drainage the CSF. At below the 60 millimeter mercury, we have after system we have a lot of CSF will come out at the drainage. For every day we can drainage more than 100 until 200 milliliter. At I usually use, I think in my experience, the basal cister drainage is better than EVD. There's a lot of CSF come out from basal system. Every patient is the in this situation. So there's better than EVD's drainage. And actually, when my team doctors, residents do cystostomy, they can learn the microsurgical skills and prepare for vascular surgery. It's spent for their program, for their education. So there's a very good surgery resident training. Actually, we in my pre-hemorrhage, if the after surgery, if the breath relax, very relax, and this time ICP is low, below the 10 millimeter mercury, we can replace the bulb. If the breath is swollen, and the ICP is high, we cannot replace bulb because at this time the CSF cannot come out. The breath will swallow after surgery.
Right.
This is my experience in this year's cystostomy.
Thank you, Dr. Wang. Thank you, Dr. Wang. Okay, we have with us Dr. Sabaresh Nadarajan from the United States, who wants to just share, who's working closely with Iype, on the trial of cisternostomy. So, Dr. Sabaresh, would you just like to briefly share, this project with you?
So, thank you, Iype, and the panelists for letting me be here. Sorry, I missed the initial part as in a case. I'm a strong believer in cisternostomy. I think it works very well for trauma because I'm in the United States and there's not a lot of data. I'm kind of forced to leave the flap off, but increasingly every day I do a smaller and smaller flap. Okay, I don't do this big 12 centimeter flap. I do a little Cherian craniotomy like I do for an aneurysm, go down to the cisterns, open it, and I leave it out. But at some point we have to create data to put it back, right? Especially in the United States. Data is important, and that is an important thing we need to think about. Decompressive hemicraniectomy has no data to prove that that is what we need to do. ICP monitoring, and when ICP therapy fails and when we need to do surgery, there is no data, right? This is all written by guidelines by trauma societies out of level B and level C evidence, no randomized control trials, no quality data. And we just added one after the other, and we have these guidelines published, and everyone in the critical care society is following it, right? Every time we go and tell someone, hey, I want to do a surgery, it's like, oh, I'm not done with medical management. You cannot do surgery. That's how aggressive the critical care specialty is, right? So I'm a surgeon, I'm not a data collector, but we need to become data collectors to fight our lobby, right? It is an important thing because if we don't become data collectors will win this battle, right? So that's an important thing. So I think it is important. We are starting a registry. We have approval to start the registry. It's going to be an online de-identified registry for cisternostomy patients. It's going to have some preoperative data, some representative images, what technique was used, was the drain used, how many days it was used, what is the ICP during this timeline, and what is their outcome disposition at discharge, and what is their outcome at around 6 to 8 weeks. That's what we're going to have in the data set. And de-identified patients can be put in with serial numbers on this database. And we just need to prospectively collect this data. and the first goal is to prove that this is safe, right? That is the first goal, and it is going to be at this point, what data do we have? We have Roy Thomas data from Lausanne, Switzerland. It's the best data available, right? And in that study, it said primary, which is you don't wait for the brain to cook, right? Do primary cystonostomy, that works better, right? And it's an adjunct still to decompressive hemicraniectomy. That is the data that is available, right? So we got to start there and make it to a place where, okay, I'm sure there are a lot of people put in the bone flap back, and we will get a sense over time of what is the conversion rate. Like, okay, we put the bone flap back. How many of these bone flaps needed to come out over the hospital course, right? We don't have the data yet. There is anecdotal data from all our people doing it all over the world. But is there a collective prospective data to show this is the percentage? We don't have that number yet. And such a registry will help us get there, right? So I honestly encourage all of you to join this registry because this is a fight against data by data. Right? And we all need to, and the other thing that I want to emphasize, it is important. The quality of surgery is important, right? If you see in Roy's paper, okay, each and one of these procedures were done by someone who was very experienced in doing vascular surgery, microsurgery, and skull-base exposure. Skull-base exposure is tailored to what is needed for these patients, right? So it is important that when you collect this data, you have quality surgeons' expertise, the best surgical technique, so that we can fight this with data.
Yeah, Sabarish.
Yeah.
Sabarish, nice of you. And actually, my paper is still waiting, and it is nearly, I think it is in the review process. I hope that whatever you want, some data is there.
Okay.
Iype knows about it. We have submitted for our earlier presentation, but we try to give 3-4 institutions. Now, mine is, it is in the process. I expect at any time, if it is accepted, that it will be very beautiful for you, because you have some data for pure cystonostomy and for in places, in some cases, with where the bones are removed. And it has given a good, reasonable study. And I think you can have it. I hope I'm looking forward that paper.
I'm looking forward to it, but I think about the stages of this. First, we need to say that this is safe to do. Second, we need to say that this is as good as comparable to decompressive hemicraniectomy. The third step is you don't need a decompressive hemicraniectomy. The fourth step is what is the timing to do this, right? And that's when we are in the game, right? And then we talk about how we can refine this, how can we advance it, patient selection, can we do selective techniques? All that comes after, right? But this is how I think about the chronology of how we need to get to where we need to get. And I think this is just a start. Yes, it may take 10 years, but we need to start somewhere, and we need to create momentum, and we need to create joint hands from all over the world to do this.
Yep.
Thank you, Sabarish. Thank you, Sabarish.
One thing I wanted to tell you about the middle cerebral artery infarctions. I think it works in those patients too. The middle cerebral artery infarction patients, I don't do a big durotomy like I used to do before. I do a small durotomy, go in and drain the cisterns. And after I drain the cisterns, the brain is very, very slack. And after that, you open the dura. It's like, why did I open the dura in this brain?
Yep.
Right? And I still leave the bone off, and I never see the brain even coming out of the skull.
I have a very small experience on this because I think there is a paper also published on this matter. I did few cases. It's a very, very handful cases, 2 cases where, but we selected very early MCA tertiary infarct. You have to pick up very early. And once you pick up very early, and then it is absolutely easy to do a cystonostomy. And I'm telling you that maybe in the next meeting, when I have an opportunity, the next meeting, I will show you that, including with my video. You believe me, you find a very good, you see the cortex, you see they are a little bit pale. But then when you do the cystonostomy, it relaxes. I do not know whether it is working on the same same hemisphere or that hemisphere, but whatever said and done, relaxes. And I didn't take out the bone flap.
Yeah. And
Then
24 to 48 hours is the timing that I do. 24 to 48 hours when there is no brain swelling, not after the brain swells.
Absolutely.
After the close the pupil, not at that time.
Absolutely. This is the point which I in fact that I also experience, because it is you have to be more aggressive in these cases, and not that you wait for, as you said, that somebody cook and then wait, let us see tomorrow, let us see the day after tomorrow. Obviously it is going to, an ischemic process which is going on is going to go on. So it is
fight
better
against
to,
ischemia of the brain. It is a fight against ischemia of the brain. You catch the brain before it becomes ischemic, and there is peripheral ischemia and a penumbra developing in the brain, then you're there. The other point I wanted to say, if the brain is not slack after you do a cisternostomy, after you do the drainage, okay, what I do is I use an intraoperative ultrasound. So you can put an ultrasound on the brain surface, you can see all the way around across to the other hemisphere, right? And that'll tell you, is there an intraparenchymal hematoma? Is there a subdural hematoma? Is your ventricle still full? Do you need to open the lamina terminalis? You can do all of that with an ultrasound in the OR. So that way you don't need to close the head and then get the patient for a CT and bring him back into the OR.
Yeah, that's a point. Yeah, it's a good point. Yeah.
Yeah, it's a good learning for me also, because I used to take up these infarct patients once they developed pupillary dilatation or pupillary asymmetry, and that is when the neurologists referred these patients to us. And that is probably why my bad results initially with for malignant MCA infarction. But I guess I would tell the neurologist the next place that I'm off to Pune now. I'm going to be settling in Pune. And the neurologists there, I'm going to have discussions with them that if there is a patient who comes early, and if we can catch them early, we can do cisternostomies before the brain swelling starts. I'd be able to tell you how things are.
Honestly, in MCA, you already have data for that, right? If you think about the trials done for decompressive hemicraniectomy in MCA, right? All those trials were done on preventing prophylactic decompression, right? So you already have data for that. You don't need to argue with your neurologist for that. You can say, look at Decimal, Destiny, Hamel, all these trials, okay, were done 24 to 48 hours decompression, not after 3 to 5 days once the brain swells. They were all prophylactic decompressions. So you don't, I have to argue with the trauma perspective. I don't need to argue as far as the middle cerebral artery perspective, because, there's data. And that's where we need to get with trauma too.
Yes, I get it.
Right. Yeah, let's hope after this, many more will join this effort. I think Malaysia will be happy to contribute. I think I've been working with Iype. We've got about 60 patients already recruited with
Fantastic.
So let's look to that in the future. And we have to thank one of our former residents who's now a neurosurgical specialist functioning in Johor, who had done some training with Iype, Dr. Rakesh, for his efforts. So we'll be in touch soon. So I think it's getting a little bit late. There's been still a lot of questions coming in. Some perhaps the panelists might try to directly answer in the chat, but I think we'll probably have to close the discussion for this evening. Thank you, Iype. Once again, it's been a pleasure. Dr. Parthiban, Dr. Wang, and of course, Sabresh, thank you. Some interesting perspectives. Let's hope to, work, move on further with this and, lead the charge in trauma.
Yeah.
Right. With that, I thank you all and I wish you
trauma. That's what it is.
Thank you, Raghu. Thank you, Sabarish. Thank you, Parthi. Thank you, Wang.
Thank you. Thank you, all of you. Yeah.
Thank you.
Good night.
Good night. Bye-bye.
Bye-bye. See you.
We have to say Nicole, and she has to say something at the final with the panelists, something she was talking about.